Hello, may I have your attention, please? I'd like to welcome all of you, but before we get started, I just want to let you know there's library books to check out. They're on the table in the back of this room. You can carry them down to the Popular Lending Library for that. The bathrooms are right over here, men and women's room. And we have a survey outside. If anybody is interested in more information on this topic, there's so many different opportunities for things to talk about that you can write down what your interests are or indicate on the sliding bar how interested you are in some of the topics we've broached. And there's free materials, so you want to get one of these if you don't have one already. And the other things that the Philadelphia Department of Public Health and the Office of Emergency Management have for giveaway today. There's a trash can in the corner of the room over by the books. And then also, let me bring your attention to situation reports that have been printed out from the World Health Organization. They show the growth of an expansion of this outbreak. So the very first one is on the wall over there. It's just one page. So it shows the number of people who have caught this and how many people have died. The next page, it shows a world map as well as what's on the first, and then a breakdown by country and a bar map. Then the third week is over here. So it's week 1, week 8, week 15 is over there, week 22, and so forth. And you can make comparisons on each of those, on how things have been changing. And why we find it relevant to do a program on this. There's also a breakdown of the virus itself. It shows in color the very first 8.5 by 11, 8.5 by 14 piece of paper shows both SARS, the original SARS, and COVID-19 listed as Wuhan flu. So. Also, I'd like to thank all the people who have helped in putting this together. This has been done, on a short-term basis. So I want to thank my administrator, Rebecca Ray. I want to thank, who's right here, Lori Alper, one of my colleagues, Benita Riggins, who you've seen floating around. She's currently out welcoming people coming in. Our podcast and videographer, Terry Ray. And we have several volunteers. We have a young lady by the name of Rebecca and another by the name of Bruce who are redirecting traffic. We have all our helpers from the Office of Emergency Management. We have Josh, and we have, I can't remember his name, but these two gentlemen over here. So we'd like to thank all of them for their help in making this program come together. So now, introductions to our panel. First off, we have Dr. Stephen Alice, this gentleman right here. He is the director for the Division of Disease Control at the Philadelphia Department of Public Health, and he will be giving an overview of the coronavirus, COVID-19. And then next we have Mr. Derek Ziegler. He is the Deputy Director for Planning Emergency Management. And third we have Dr. Curtis Miyamoto. He is the professor and department chair in oncology for Temple University Hospital. He's the professor and chairperson, Temple University Physician Advisory Committee of the Philadelphia International Medicine Consortium, which also represents Jefferson, Penn, Fox Chase, et cetera, and the Philadelphia County Medical Society. And he is a past president for the Board of Medical Direction. And we chose him because he was referred by the Asian Health Collaborative, which are a variety of Asians in Philadelphia from across the Pan-Asian countries. And he can comment on the impact on the Asian community in Philadelphia, including Asian care providers, the impact on his own personal practice and questions patients are asking, and the Temple University, where he worked, the health system's response. So now I am going to turn the microphone over to Dr. Alice, and then after that we will have a question and answer. Thank you.
I think so. put this right up here. This is fine. This can be right here. That's okay?
Yeah, well, that's podcasting and this is AMP.
Okay. All right, good evening, everybody. I want to thank Barbara and the library to invite us here to give a talk to you about the novel coronavirus situation. I'm going to do a couple of things. I want to talk about internationally, locally, nationally, what's happening with this disease, and then I want to touch on what the city's been doing to respond to what's happening, and then leave you with some important messages around what you can do right now to prepare and to hear what we think is coming in the coming weeks and months, and what you can do to prepare for what those days might look like. I'm not really a funny person generally when I talk to crowds, and I'm trying to work on that. So I do have a joke, so I'll just tell it. What goes well with coronavirus? Lyme disease. Yeah, a little public health humor. All right. I promised to. Thank you. That was a breakthrough for me. No. But I would like to ask a question, and I would like to get an honest response from everybody, if you wouldn't mind. So, by a show of hands, how many people in the room tonight got a seasonal flu vaccine shot this past fall between August and December? All right, I appreciate those that didn't raise their hand, and I'll come back to that idea later as I discuss this emerging infectious disease in the community and how it relates in several ways to seasonal influenza that we deal with every year. All right. Okay, so just to go over what are coronaviruses. And so coronaviruses are known viruses. This is not a brand new family or class of viruses. There are common cold coronaviruses that happen to people every winter. Typically, those viruses don't make a lot of people very sick. It's like a cold. So most people get sick for a handful of days, maybe stay home from work, some press through, all of that. Typically, that's what coronaviruses are and do. However, there have been a few that have lived primarily in animal species first. Bats is a good example, and then every so often, 10 years or so, a coronavirus like that will jump into a human through an intermediate animal reservoir. So from bats, say, to camels, or bats to civet cats, and then get to humans that are in close proximity to those animals and cause then disease in humans. So that happened in 2003 with SARS, severe acute respiratory syndrome, primarily affecting places like Singapore, China, but also Toronto, Ontario, and Canada. And then MERS-CoV, Middle East Respiratory Syndrome. That's kind of been a percolating threat from mostly Saudi Arabia. Korea had a problem with that a handful of years ago. Still continues to be a small threat to us here in the United States. And now this new coronavirus called COVID-19, novel coronavirus, those are the terms we're using, that's believed to have jumped from an animal reservoir in Wuhan City, China, into humans and then has spread between humans. So viruses get to change their ability to transmit between different species when they're able to jump between and into new species. So the transmissibility is a very important concept here with all infectious diseases. The other is severity. And so I'll touch on both of those elements when we're thinking about a new disease that's spreading in the community, how easily it transmits between people and how severe it is when it infects people. All right, so how is this particular coronavirus spread? One thing I do have to say, and I know everyone says this is an evolving situation. That's absolutely true. And so how do we know how it's spread? How do we know who's really at risk? How do we know what symptoms they get typically and how severe it might be? How many people it will kill? How do you control transmission? What protective gear should healthcare workers wear to protect them from getting the disease? What effect do masks have in the community to prevent getting transmission? We don't know. We can guess based on other coronaviruses that we have done studies on, or CDC has done studies on, or the World Health Organization has done studies on. But for new viruses like this, some of that stuff is just unknown. And the only way to know for sure is after cases happen and investigations happen to interview those cases, to ask them, when did you first get sick? What were your symptoms? Some people have had fever right away. Other cases haven't. So to say fever is always the first symptom in this disease, that's not true. Some people don't get that at all. So I'll describe some of the differences that happen with this disease in different populations. As time goes by and more cases happen and more investigations occur of those cases, we learn more and we get a better picture of what we can do to prevent transmission and how to protect ourselves. Okay? So that's the first big part of it. It's an evolving situation. We don't have all the answers, but as time goes by, we know more. Okay, so how is it spread? This virus is presumed to spread through what we call droplet-mediated transmission. So it's a respiratory virus. It's in respiratory secretions. When you talk, cough, sneeze, you're spreading droplets that may contain viral particles. They settle. So about a 3 to 6 feet distance from, say, me, would land on the table, the podium here, but it wouldn't affect these people right here in the nearby rows. It would just be too far. They'd settle out before that. So for a healthcare worker with a sick patient, they are at risk. They are in that range. So that's why they need to wear protective equipment so that they don't get the virus on their face. So they're supposed to wear a face shield or goggles. That's primarily the way transmission is thought to occur, in close proximity to a sick person. Now, this question of can you transmit this virus before you're symptomatic? We know that that happens with influenza viruses. A day before you're first symptomatic, you can transmit because you start to shed virus in your respiratory secretions before you get your first fever. Does that happen here? And again, at first, we don't know. There is some evidence, some information coming out of China where most of the first cases happened to suggest that does happen. But we have not seen that data. We have not vetted that data. We don't know what the time frame is. Is it just 4 hours before symptom onset, 24 hours? And those are arbitrary figures. When you hear numbers like 24 hours, 48 hours, those are very convenient numbers. And this is the world of science. And so I always kind of raise a little red flag there to go, 24 hours sounds very convenient. And it's probably more maybe 20 hours or 19. I like numbers like 17, 23, 9. That's one of my favorite numbers in science. So we don't really know. We don't have definitive data to tell us that people can transmit virus before they're symptomatic. Maybe, if they can, probably not longer than a day before, maybe half a day, maybe 7 hours or 5 hours. We just don't really know. Okay, the illness typically, so another important concept with an infectious disease is incubation period. And what that means is, what is the time frame between when I got exposed to it, so I, say this gentleman was standing right here and I got the virus and I talked or coughed on him. That's his exposure. How long does it take him now to develop his first set of symptoms and declare himself as a case? Now he's going to be sick. That time interval is critical because that's the period we have to watch people to see if they actually become a case and then can spread it to somebody else. And so originally we were using this time frame of 14 days. And again, how convenient, 2 weeks, 14 days. So that's really, there's some arbitrary decisions being made around 14 days that I think make it a little bit more convenient for people to track. We don't really know what the incubation period is at first. Now that there's a lot of cases, over 80,000, most in China, there's been some good data to tell us that the incubation period looks like 3 to 7 days, 3 to 4 days. So that means if you're going to get sick after an exposure, likely by day 7, you've come down with your symptoms. And it doesn't apply to everybody. There have been a few outliers that go out further than that. But the middle measure of when people get sick is 3 days. And that's good. That helps us, because if you're going to get sick, people are going to get sick faster, and then we can know about them and try to control spread. All right. Okay, so I'll talk about the symptoms. So who's getting this disease? I think this is important too, because that varies for a lot of diseases, and it applies here too. So generally speaking, with this disease, who's getting it and getting very sick and dying with it are older people. Again, 60 is the age, and how convenient, 60, not 59, not 62, but around, people that are older in life, and people that have underlying chronic health conditions, and primarily respiratory problems like COPD, emphysema, diabetes, renal disease. Those folks, unfortunately, are more likely to get severely sick with this disease and die. There have been cases in younger people, otherwise healthy people, children, but there's a lot of mild illness that we're hearing about in younger healthy people, children in particular. So this is not a disease that's primarily affecting children, babies, and healthy adults, young adults. More likely worse seniors, and people with chronic underlying health conditions. That's like seasonal influenza. So there's a corollary there with that disease. All right, so what are the symptoms? Fever was something that was said part of the case definition when we're looking for people who might have it. Travel to China and fever. Then there was a report on a lot of cases in China that showed that upon presentation, only 44% of patients said they had fever or had fever that was measured. So that's less than half. So fever isn't really the best predominant symptom. Like influenza, that does typically present with fever right off the bat. So, but not so much here. It can be present for people that were hospitalized and got severely sick with coronavirus. Fever was present 88% of the time. So it is likely there and part of the clinical picture, but not always there at the beginning. Cough and shortness of breath or respiratory complaints were more predominant in people when they first present. And that helps us when we're trying to figure out, could this person have this disease? We want to hear more about cough or lower respiratory complaints first. That's a little bit better for us to think this could be it, rather than the presence of fever or not. Both, that's worse for that person, because that makes us think if they have fever and cough, that's the combination we're actually looking for. Okay, other complaints have been noted in some patients. So is it a gastrointestinal or GI type of illness? Not really. Some people have talked about diarrhea. Some people have mentioned headaches, fatigue, myalgias or being sore, having muscle aches, that kind of thing. But not everybody. It does predominantly transition into a pneumonia or a severe lung infection, requiring hospitalization for folks that do severely badly with it. So it's primarily a disease of lungs, fever and respiratory complaints. Kidney failure has been reported in some severe cases, and then people have died. And I'll share with you the statistics and the counts currently, internationally and here in the United States, about number of cases and number of deaths. There's no treatment, so there's no medicine to give, like there is for influenza, something called Tamiflu you may have heard about. You can give a patient who's sick with influenza Tamiflu early in their illness, and it'll get them better faster. You can also give Tamiflu as a medicine to someone exposed to flu to prevent them from getting flu. We don't have that here with coronavirus. No medicine to treat it or to prevent people from getting it. There's no vaccine to coronavirus either. Vaccine is given in advance to protect somebody. They build their own immunities and antibodies to that virus so that when they do come in contact with it, their body's ready to fight it off and they don't get sick. So there's a flu vaccine for influenza every year. Why we recommend it? Not one here. So no vaccine, no treatment. Makes it harder for us. All right, let's talk about death rates. So this is an important component of any infectious disease. Transmissibility, how easily it spreads between people, and then how severe it is. And so we have to look at death rates. I mentioned SARS from 2003. The death rate is out of the total number of people we know who have the disease, total number of cases, how many die. That fraction is the death rate. And so for SARS, 14 to 15%. That's very, very high. So out of 100 people who get SARS that we know about, 14 die. So, and what I will say is we often know the deaths because you can't hide a dead person. They are reported, we find them, and we can diagnose them, and so we know the number of deaths. What's hard for us to get our head around is the total number of cases. And so if there is a lot of subclinical or mild illness in the community, like with children who don't present to healthcare because they're just not that sick. They stay home for 3 days, they get better, never present to healthcare, we never know about them. They should be counted in that denominator of that fraction, and they're not. So when I share these death rates with you, chances are these are overestimates, and the real number is less than the figures I've got on this slide, especially for the novel coronavirus. So for SARS, that death rate is 14, 15%, extremely high. For MERS-CoV, Middle East Respiratory Syndrome, for whatever reason, it's very high, 35%. Haven't been a lot of cases there, so transmissibility with that disease is less. Severity, though, very high. So that one we take very seriously. Both of those coronaviruses are very high risk for healthcare providers, people who will be right in front of and taking care of people sick with the disease. So that's an area or a subpopulation that we care particularly a lot about to protect them. But for the current novel coronavirus, the death rate is kind of sitting, we don't really know it for sure because we have to let more time go by to count cases and count deaths, but it's looking like it's somewhere between 2 and 3%. I actually think it's lower than that, and I'll show some data about what China's statistics show us, what South Korea's statistics show us, and what the United States statistics so far are telling us. So good news, not as fatal as SARS and MERS-CoV, but even 2% is still very high. 100 cases, 2 people die. You multiply that with something that transmits easily in Philadelphia, affects 10,000, 100,000 people here in the city, that's a significant number of people dying of the disease. So it is something to take seriously. This map I made on Friday, it's kind of still relevant, but it won't be by Wednesday, I'm sure. This is, I've circled, all the dark colors on here are the countries that have reported cases. There are countries that are missing on this map, because I know that several other, I think a few African countries, New Zealand, Iceland, a handful of others have identified their first cases, and they're not colored in here. But I have circled around the 5 countries that are now considered very high transmission and have travel warnings associated with going to those places because of this disease. China is the first one. Japan, South Korea, Iran, and Italy. Those are the 5 countries right now that no one should go to, at least from this country. Just avoid going. This is not the time to visit those places. What I will say is every day there are other countries that are reporting many more cases. France, Germany, there seem to be 2 that are now really escalating. I think the Italy outbreak early on has spread to Europe, and so the United Kingdom, Belgium, other places, Norway has 19. That's suddenly getting more. And here in the United States, we're detecting more cases too. So we're all starting to see more cases. All right, so now let's look at some numbers internationally and then here in the United States. So this is as of today. I went on both CDC and WHO's website to get today's numbers. This will be old by tomorrow. 89,000, almost 90,000 total cases reported in the world. Most of those, 94%, are from China. It was about 99.9% China a month ago. But other countries now are starting to expand their numbers, and China doesn't have as much of the total burden as it used to. The total death rate, the total fatality ratio, is 3.4%. 3,056 people have been reported to have died of this disease. 3.4% is alarmingly high compared to other infectious diseases like common colds, even influenza that we have every year. This is a high death rate. It's less than SARS, less than MERS-CoV, but it's very worrisome. Okay, 67 countries currently have reported cases. South Korea is now number 2 behind China. China clearly has the most. I think they have over 80,000. So there's like another 9,000, 9,500 cases out there that are not from China. Korea is in second place now with 4,200. And they are rapidly expanding. Their ability to test people has been impressive, and so we are seeing a lot of, like 600 new cases a day. That's how it's been the last couple of days. And so the deaths that they're reporting, there were 22 of 4,200. That case fatality ratio is 0.5%, 0.5, much less than 3.4. So what does that tell us? It may be that Korea is doing a much better job of counting all the cases that they can find. And so like I said, that case fatality ratio, all those people that don't get severely sick, we never find out about, they're probably doing a better job of finding them, testing them, and counting them in the denominator of this ratio. That's why it's 0.5%. So what's the real death rate? What does that mean? It's somewhere between 3.4 and 0.5%. It might just be about 1%. And I'm hearing a lot that that's really what the realistic estimate is, probably about 1%. Number of new cases in China have decreased per day. This is interesting, and we're looking at this very closely. The questions are, is this going to be a disease that spreads throughout the whole country and a significant proportion of the population is going to get it, mildly, 1% death rate, whatever, or is it going to just affect some people and go away? And what's happening in China is the number of new cases that they're reporting is significantly less. It's down to like 200. Korea's reporting 600 a day. China was reporting 1,300 a day not too long ago, 2 weeks ago. So, you know, you may have read or heard about these pretty strict control measures of quarantine and shutting down big cities that they've got with a lot of people. Is that having an impact? Potentially. So I think the good news is that with a total of 80,000 people infected and a reducing number of new cases per day, China is, I don't know how big it is, like 1.5 billion. There's so many more people in China than the 80,000 that have not been infected. So what it's looking like is it may be that this virus will spread to some proportion of that nation, but not everyone. And sections of big countries like China may not be affected heavily, like Hubei province or where Wuhan City is located. So more to tell. This is an interesting story for us to watch to figure out what's it going to do here. But what happens in China is really telling us a lot about what we might be able to expect here in the coming weeks and months. All right, so what's happening in the United States? 88 confirmed cases. That took a good jump. A handful, like not quite, more than half, are repatriated, meaning that we brought them back from a place like Wuhan City, China, or the Diamond Princess cruise ship that was docked off Japan. The Americans that were there that have been sick that got the disease. So 48 of the 88 got it in Wuhan City or on that cruise ship, and we know about them, and now they're back in the United States. But the rest, 40 of them, got it here, or we picked them up here. They traveled separately by being in China or wherever, came through an airport, and then they reported to healthcare. They got sick, and they were picked up by the healthcare community and tested, and were found to be positive. So 14 people met that criteria. 12 people actually met that criteria, but to make the 14, there were an additional 2 people who got disease from very close contacts of those 12. Marital partners. So 2 people, close contact, family members of the 12 got the disease, telling us that very close proximity, a marital partner, husband, wife, whatever, that relationship of close contact can spread disease. So that's not a big surprise. Viruses like that spread like that. So that, we think, happened with those 2 people. But now there have been an additional 26 cases that did not travel to China or another part of the world where transmission is happening heavily, and they don't have a known contact to a confirmed case here in the States or anywhere else. Where did they get it? Somewhere in the community. An undiagnosed case. So what that tells us is it's here. Not necessarily in Philadelphia, though we think it could be, but definitely on the West Coast. Most of these 26 cases are being reported in California and Washington State. And we think that importation into the community is probably worse there, but likely is going to spread west to east. And so New York City reported their first case over the weekend. Rhode Island's got 2. Boston had a case, I think 3 weeks ago. Florida has 2 cases now. Chicago is early. They have 2 cases. But most of the cases in the States right now are in California and Washington. Arizona's got a case, and Oregon just reported their first case. There have been 2 deaths of the cases that we know about in the United States. So of the 88, 2 deaths, 2.3%. What's that? 6 deaths. Before I left the office and came here, 4 more reports have come in of deaths. Okay, all right. That's not good news. But all right. Evolving situation. Thank you. All right, and just a map on the states that have reported cases. Do you want to update this for me right now? I'll hear it. All right. Again, it really is predominantly right now, at least to think about it, a West Coast phenomenon more heavily than what we think is happening here on the East Coast. Could change rapidly, though. All right. So my next question is it worth all the hype? So this is being covered heavily by the media. We're all getting bombarded with stories about each new case. A country declares a case, a new death in a case, in some jurisdiction. You see all these health officials going, public, stating that we have our first case. And we're going to do that. We have plans to do that with our health commissioners to engage the press and announce that we have diagnosed the first case in Philadelphia. It might be the first case in Pennsylvania. We don't have a case in Pennsylvania or Philadelphia. New Jersey doesn't have a case yet. Delaware State doesn't have a case yet. So we plan to do that. But, the Diamond Princess cruise ship, the doctor in Wuhan City that died, the president going on TV last week. All of this stuff is just a bombardment of every day. It's really on this level I've never seen before. Is it worth all the hype? And so I'm not going to answer that question now, but what I need to do now is talk about another infectious disease we have all the time that heavily impacts our country and our city. And does this get press coverage? No, right, it doesn't. So I just say this to you so that you think about, what are you reacting to? Are you reacting to reality and science and health officials telling you things? Or are you reacting to another story on your online news source or in the newspaper or wherever you get your news from, or what people are talking about in the office, your friends, your family, whatever it might be? So seasonal influenza is a great analogy here. It's not perfect, it's not exactly the same, but I want to review what's happening right now with influenza, as happens every winter in our country. So the Centers for Disease Control and Prevention, or CDC, they have estimated at least 29 million flu illnesses in our country this winter season. 29 million people have been sick with flu this year. It's an estimate. It's not, we haven't diagnosed every single case, but based on healthcare utilization patterns, that's how they estimate it. 280,000 people have been hospitalized, admitted to a hospital, too sick to go home, hospitalized. 16,000 people have died of flu this winter. Americans, 16,000, right? Big number. 105 reported influenza-associated deaths in children. 105, fortunately, this is, the 16,000 isn't heavily affecting children, but 105 kids younger than 18 have died. So far, this has been a moderate flu season. This is not considered even a bad flu year. It's a pretty good one or bad one, however you look at it. It's considered moderate. It's not a light one. It's typical. In Philadelphia, what does that look like? At the health department, we track hospitalizations from people that are hospitalized with flu every year. And so you see on this graph the number of people that are hospitalized due to influenza. These are people that are diagnosed with influenza. We know they've got flu. Flu A, flu B, whichever. So currently, right now, 860 people in Philadelphia have been hospitalized for flu. Are you hearing about that in the press? No, because the press chooses not to cover the story. So it's a big deal. These people are being hospitalized for influenza. 2 years ago, 1520, that was a bad flu year in 2017-18, that winter. 1,520 Philadelphians admitted to a hospital. Did you hear about that? No. Doesn't surprise me. And so you kind of see over the last 10 years, some years, 2012 or 11, 12, 120. So that was a light year. We don't really understand why it was we had a good year there. It wasn't a lot of flu. But flu just comes back every year. There's a vaccine for it, which is why I asked folks, do you get a seasonal flu vaccine shot every fall? Because there is a vaccine to help protect you from getting flu. And if you choose not to get it, then what is your preparedness mentality toward infectious disease prevention for yourself and for seniors or people with chronic conditions that you have close interactions with? So I make that statement because I am encouraging you to think about this disease and improve or increase your preparedness around a known infectious disease that happens every year that has an intervention you can get to help protect you from getting the disease. So get your flu shot. This graph, I think, is even more compelling. These are the number of people who die in Philadelphia due to influenza. So far this year, 17. 17 people have died, Philadelphians. Is that in the news? No, but you better believe as soon as we get a coronavirus case admitted to a hospital or that dies, all over the news. You're going to see Commissioner Farley having to say stuff about it, but no one really seems to care about seasonal influenza deaths. So again, context. We have stuff like this all the time that doesn't catch media attention, and that drives public interest. All right, so is it worth all of the hype? Should we be concerned? Yes, we should be. Because this is a new infectious disease with a lot of unknowns. We don't know what it's going to do. 1% case fatality rate is bad, and we're starting to see transmission in our country. And we do expect to see cases here in Philadelphia. How many, how much, we don't know. Okay, so I'll talk about what we're doing and what our posture is in the city's health department. So I'm the director of infectious disease control. We deal with STD control, sexually transmitted diseases, foodborne outbreaks, Salmonella, Shigella, E. coli, vaccine-preventable diseases like measles, mumps, pertussis, influenza, other diseases like Legionnaire's disease, vector-borne diseases from animal bites, mosquito bites like West Nile virus. This is the stuff we do all the time, every day. And so we do a lot to try to control the spread of all of that. And so what can we do here with this new disease? So the big thing right now is to detect cases. We got to find our first cases and try to isolate them so they can't expose other people, protect any healthcare workers that might be caring for them, protect any family members that might be caring for them if they're not too sick to be hospitalized, because we want to prevent transmission. So it's detection and containment. It's been working in a lot of places. If you recall, the first case diagnosed in the United States in Washington State happened a long time ago, like 5 or 6 weeks ago. There was not a secondary case from that person that we know of, and many weeks have gone by, like 5 or 6 weeks, before they declared their second case. So we do think that detection and containment of initial cases and contacts works to an extent, and we want to delay it as widespread transmission. That's what we don't want to have happen. But finding initial cases and controlling spread is our strategy right now, to the extent that we can actually not allow widespread community transmission. That's our goal. So we have to analyze who gets very sick, how it is transmitted, and make additional recommendations to limit transmission. That's working collectively as a country and as a world to understand all the cases and the parameters around people who are getting sick. Protecting healthcare workers is a priority. They are the front line. They are the ones that we know are in harm's way. They have to be wearing the right personal protective equipment and be working under the right conditions so that they don't get disease. And then learn and prepare better in the future. We have been planning for pandemics for a long time. Office of Emergency Management here, my colleague Derek Ziegler, knows well that our agencies take this seriously. We try to do planning. We don't get a lot of participation because until a year like this, no one really takes it seriously. And so it's hard for us to get people to care, agencies to care, to think about how to be ready for a time like this. But I think that the lessons that we're learning this year hopefully will resonate with a lot of agencies and the public to say, maybe by next fall when this is all over, we can roll up our sleeves and really get some good strategies in place around seasonal flu prevention, but also whatever the next big infectious disease might be. Who's at risk? Right now, and probably when there are cases, and that's kind of how we're looking at this right now. What's the story now? And then what might it be in the future when we've got cases in Philadelphia, because we expect we will. So it's travel right now still. So if you've been to these 5 countries, these are on the travel warnings from CDC: China, South Korea, Iran, Italy, and Japan. But I would say I have potentially other places with increasing cases on here. That's not part of CDC's case definition. But if somebody was in France, Paris in particular, where spread is happening in France, that could be good enough to want to test such a person. This list is going to continue to change. Is the West Coast now, Seattle, considered a place where you could have gotten it if you traveled to King County, Seattle? The answer is maybe, yeah. And so if there's a clinical syndrome, a combination of fever and cough, lower respiratory complaints, recent travel to like King County, Seattle, that area, we might test you. And then healthcare workers who do not use appropriate protection, they're also at risk right now. That's kind of it for right now. So if you're worried about yourself right now, if you're not one of these people in this column, you probably haven't been exposed to it. You probably don't have to worry too much about that you've got it or that someone you know has it. Now, once we have our first cases here and we document community transmission, they didn't travel, we don't know where they got it from, then it might look like this. People with close contact with sick people. So if you've been around other sick people, maybe in a close setting like this, if I was coughing, hacking up a lung, if some of these people were actively sick, that might be an exposure. Nicely timed. Travel associated with places where there is more transmission in enclosed spaces. So this kind of gets into flying on an airplane. If you're going to places where their cases are, people might be on that plane, especially a long flight overseas. You're just in a closed setting for a long period of time with recirculated air. That's higher risk, I would say. And then healthcare workers who do not use appropriate protection, that's the same. People who attend large gatherings and share utensils. Now, we have seen transmission in Korea due to church. An individual who went to several church services, that kind of ignited the outbreak in Korea. And we have had cases of other diseases like meningococcus or vaccine-preventable diseases that are respiratory diseases that have been spread in church settings where people share cups, or college fraternities is a great example. We have mumps with them because don't share drinking cups, but they party, they do, and they spread mumps and other diseases like that. So those are the kind of activities that people really kind of have to be careful about, and just not spread, not share utensils, eating utensils, cups, stuff like that. All right, so I'm going to touch now on how the city is responding. My friend Derek here is going to elaborate from the Office of Emergency Management standpoint, but I'll focus on the health department. So we're working with 911, emergency medical services, hospitals, doctors' offices to make sure they understand how to identify a suspect case. So clinical syndrome, fever, cough, and recent travel. And other factors may be important now too. So they have to know that, and they have to be ready for that. They have to be asking people, did you recently travel to China? Now there are other countries to ask, and they're ready. And so we have gotten reports, a lot of reports, of people that sort of fit the case definition. We've tested 3 people in Philadelphia, all negative, and right now we don't have a current case that we're testing. But we're looking for it, we're waiting for it. We get reports from hospitals all the time, EDs, about people with travel to Philippines. Well, that's not really on the list, so we're not really testing somebody like that. Or they're just not sick enough to make us think that it could be this disease. Especially since seasonal flu and other winter viruses are circulating heavily right now. It's more likely to be one of those here in Philadelphia. All right, health department testing suspect people, following people in quarantine, checking on symptoms, coordinating with healthcare. So we've been getting lists of passengers who have traveled to China, and we've had about 400. We have been checking in with them to say, you got 14 days to stay home, not go to work, not go to school, and do you have any symptoms? And so we're relating to this population on a daily basis. Not everybody, some of them are kind of hard to reach, just to check in to see if they develop symptoms. And if they do, then we're coordinating their facilitation into healthcare, or we're going into their homes and doing the testing ourselves. It hasn't really picked up anybody, and it's not the best surveillance system. We think it's kind of partial, but it's definitely better than nothing, and it could be the way we pick up a few of our first cases. That hasn't happened yet. Okay, Health Department and Office of Emergency Management working with city agencies to actively plan and control spread, thinking about what could happen if we have widespread transmission, what is that going to look like, and how do we, as city agencies, what do we need to be doing and thinking now so that we're better prepared then? International Airport, we speak to them regularly. SEPTA is on board with us now because we think public transportation could come into question. Is that a safe thing to do for folks? And then schools, this idea of school closure, should that happen? We have mixed feelings about this. We don't do it for seasonal influenza. You get an influenza case in a child in a Philadelphia school. The school does not close. No one knows about the case. There's not a communication to all the parents to say there's a flu case in your kindergarten class of where your child goes. So again, you know, those kind of strategies, which we might be pressured to do from parents, from the school district themselves, and then to do environmental cleaning of such a school, that might all happen. And it's happening in Oregon, you know, with their case. I think a teacher in Oregon closed a school. A 15-year-old in Washington State closed that school. Schools can close and wash themselves. That's probably a good idea for other reasons. But anyway, I bring up this example as something that you might see happen. And it doesn't mean it's the right thing to do. It's something to do. It could decrease transmission. Again, children aren't really the ones getting sick, but typically children spread infectious diseases. Even if it doesn't make them very sick, they can then spread it to each other, bring it home, and then infect an older adult, a grandparent, whatever. And that we wouldn't want. Nursing homes, shelters, university student health, we're actively engaged with them because they have these international programs. So we're going to talk to them again this week about new guidance that came out from CDC. And then education, stuff like this, coming out and telling the community. We're regularly doing this now to kind of get the word out. We're primarily focused on healthcare workers right now in the clinical setting to make sure they know exactly what to do, and public messaging. All right, I talked about travel screening already, the list of passengers, home quarantine. So what can you expect? What can we all expect? More cases to occur in the United States. That's going to happen. And then community transmission to occur and potentially widespread transmission. That could happen too. So we might have a lot of cases. You might hear about it every day. The press is certainly going to cover this. And so just settle in. It's going to be a story until, I'm hoping Mother's Day it'll all be over and we can have a nice Mother's Day. But I think that might be optimistic. Maybe Memorial Day, it'll be kind of gone. Control measures to limit transmission. Again, school closure is something that might happen. And then we're getting asked a lot of questions about cancellation of big public events. Flower show's going on right now. What is our opinion of that? Should we cancel the flower show? We're not there yet, and so I think we have to take that where we are epidemiologically speaking, which means how many cases we have locally. We might make recommendations for seniors and people with chronic conditions to avoid crowds. Just stay away from whatever it might be. Phillies are going to start playing. Don't go to Phillies games. Watch it at home until this is over. But you'll probably hear things like this coming out of the health department in the city. Workforce depletion and impacts on routine services. This is a concern. So if schools close, and this is a problem, then parents have a problem in managing and taking care of their young children that now have to be supervised. So that means they might have to call out from work. And if people are sick, and if people are fearful of going to work for whatever reason, there could be this increased absenteeism due to real disease or managing other elements of what's happening. That could be a problem. And so we're emphasizing now for employers to think about how to sustain business functions, how to keep running, how to keep operating during a severe workforce depletion situation. And then avoidance of cancellation of mass gathering events I mentioned. All right, key planning priorities for community-wide transmission. Implementation of social distancing measures. That's what we call social distancing. It's just keeping away from other people, staying out of the community. Talked a lot about cancellation of events. COOP, continuity of operations planning, is what people should be thinking about from a business, a professional sense, how to maintain functions. Messaging for personal community preparedness, healthcare surge. This is kind of a big issue. If a lot of people get sick and need to present for care and get diagnosed, do we have enough capacity to manage that surge? And then resource needs. But messages for you guys, for the public, I would say, this is a big message. If you're sick, you should stay home. And it's this element of having a little bit more mindfulness for protecting the community. You know, if you're sick with an infectious disease, don't go out in the community. Don't go to work. Don't go to school, whatever it might be. The same thing is true for something like a vaccine. So you may choose not to get vaccinated for yourself or your child. I think that's a mistake. Unless there's a severe medical contraindication why you shouldn't get the vaccine, you should get the vaccine. Not necessarily to protect yourself from that disease, but it helps protect your entire community. And so I do think that a disease like this, what can be good is that it should remind us all that we have a role to play in the health of our community, not just ourselves. Practice good hand hygiene and respiratory etiquette, use disinfection wipes on shared surfaces. A lot of environmental cleaning, that'll be a thing. Buy some Clorox wipes, use them. Avoid large crowds, I know I kind of will. Do not travel to affected areas. I would limit my travel. Do not use face masks if you are not sick. So if you want to talk about face masks, I can give you some information about, they're really used to, if you're sick, to stop you from spreading it. So if I'm sick, I'm up here, I'm talking to you people, I might have a mask on my face. Now when I cough and talk, virus particles are going inside the mask. They're not going out into the 6-foot cloud I talked about. That's a way to control transmission. Sick people should be wearing masks, especially if they go out in the community to a doctor's appointment, to get medication, to pick up groceries, something like that. Do wear appropriate protection if caring for a sick person. Maintain a 2-week supply of water. I mean, these are good preparedness statements we say all the time. Have water in your house. Keep your gas tank full, or more than half. Maybe keep some cash around if you got extra cash. And then I do want to talk about our handy-dandy Everybody Ready handbooks that Mike Anise from our program has brought over for you guys. Please take one. It's not just for pandemic or infectious disease preparedness. These are really for individuals and their households to just write out stuff about different chronic diseases you might have, contact information that you might need to track. You can float through it. There's a lot of city resources, agencies that can serve different populations that might have special needs or disabilities. There's also other things that we have up there, like this health information card. It's a good little wallet-sized fold-up number that you can, for the individual, to write out all their medications and chronic conditions. If you're found down by an EMS provider or you have to go to an ED and you're unconscious, this is a gift because it tells those providers what your conditions are and what medications you're already taking. Big help. Because it's the library and people like to read, there are bookmarks, cover your cough. It's one side in Spanish, one side in English. It's kind of fun. And then we generate like a community statement that gives lay people, not in the health profession, information about this specific disease. And so we have these flyers called health bulletins on coronavirus. All right. I'm not going to touch on this slide for guidance for the private sector because I don't think I've left Derek anything to say. And so this is really about how businesses should prepare, so I'll skip that, and then just some resources, web-based resources. Okay, that's it. I'm done.
Thank you, Dr. Ellis. This was an excellent presentation. Thank you very much.
You're welcome.
So now for Mr. Derek Ziegler. He is the Deputy Director for Planning Emergency Management, Office of Emergency Management. Thank you.
Good evening, everyone. Thanks for being here. I am going to be pretty brief. I just wanted to kind of highlight a few things that Dr. Ellis talked about and a few other things that the city is doing to prepare. So in the Office of Emergency Management, our mission is to promote a more prepared and resilient Philadelphia. So we do that by working with the community, with other city agency partners, and with partners throughout the city on a variety of hazards, not just public health hazards, but hurricanes, large special events. We help plan for those, and a lot of other different types of situations we find ourselves in the middle of. Our role is primarily support and coordination, bringing the right people in the room or on the phone together and sharing information. So Dr. Ellis covered a lot of this, but I just wanted to highlight some preparedness actions that are relevant both for COVID-19 if it comes to Philadelphia, but also other hazards as well. So Dr. Ellis highlighted a few of these, but again, making sure that you're prepared at home. Having all your medications on a card is helpful. Think about storing non-perishable food or extra water at home if you are homebound because you're sick for an extended period of time, making sure that you're ready to be self-sufficient at home. We also talk to your employer about finding out whether you can work remotely. That's not something that we necessarily do great in city government, but I know a lot of private sector employers are ahead of us in that game and having the ability to work remotely. Work and be prepared if your child's school or daycare needs to close, how you will deal with that and kind of how you can make arrangements if there's a sudden closure or an extended closure. Finally, this is something that we do stress quite a bit, is looking out for elderly relatives and elderly neighbors. The most prepared and resilient communities are ones where people have a higher degree of social capital, which means that they have a connection to their community, connection to their neighbors. Our office helps promote that through our Ready Community program in various neighborhoods throughout the city, where we really try to build up community capacity to respond to emergencies and potential disasters. So if you have elderly parents or relatives, consider how you'll care for them. If they rely on a caregiver, make sure that you have a backup plan in case that caregiver gets sick and is unable to work. Similarly, look out for those most vulnerable on us. I know in our planning for this, we are constantly thinking about places like nursing homes, personal care homes, and so on, just making sure that those facilities have support they need and are prepared properly in case they see some cases of this here. So some of the relationships that our office has and some of the things we're thinking about, working with the hospitals, working with the health department, having at least weekly calls, probably ramp that up more frequently, talk to them closely. If we get to a certain point, we'll have them work with us in our emergency operations center to just kind of coordinate everything for the city, figuring out where there's particular taxing on healthcare demand. Similarly, for private sector, making sure that our business community and nonprofits, cultural institutions, and so on have the information they need. So just highlighting this slide, working with our business community to make sure that sick employees can have flexibility if that's possible, emphasizing basic hygiene at work, performing environmental cleaning if necessary, and then just making sure that they're up to date on the most current information, and as well as talking about continuity of operations planning. So what you need to continue your business functions after a certain time. Incidentally, that's something we're looking very closely at the city government level. So how can the city maintain essential services and not just, so obviously things like first responders, police, fire, but also some of our other essential services like licenses and inspections or the water department, any number of things that help make city government work for the people and how we can keep those up and running. So the last point, our office has a text and email notification system called Ready Philadelphia. Josh, who's here, had passed out some information on that. Encourage you all to sign up to receive text and email alerts. We'll keep you posted on that. And I think that's about it for me. So I think there'll be an opportunity for questions later. But.
Thank you, Mr. Ziegler. Our final panelist is Dr. Curtis Miyamoto, and he is a representative from the Asian community who will be able to speak to the impact that this has had so far on many members of our community here in Philadelphia, as well as abroad. Thank you.
Okay, thank you, and thank you for everybody for being here and for inviting me, and for the Asian Health Collaborative that felt that I was a good representative for the community. As you know, and you saw in the slides, that this really started in China and has expanded from there, and is still affecting a lot of Asian countries. Some actually in the midst of it, and increasing in numbers, like in Korea and in Japan and places like that. So I guess it's a little natural because we're easily identifiable, right? Nobody is confused of what am I Asian or not, right? You can identify me very easily, and so people began to then look at Asians and start saying, well, you guys are the center of the disease, and started looking at us as human beings oftentimes do, a little naturally, in a little bit of a prejudicial way, thinking that we were all vectors of disease and we were carrying it to people. In fact, I don't know if you guys have been kind of looking at that out there in the public, what's been going on, for example, in Melbourne, Australia, right? I don't know if you saw that, where they said in the Royal Hospital for Children, they didn't want Asians to take care of their children because they thought we were the carriers of the disease. Well, as you saw, it's not just Asians. Well, I guess you're going to start, going after Italians. And it's interesting that in Italy, what happened, right? Did you see that on YouTube? And I'm sure most people did, where a Chinese tourist was coming and it was attacked. Like, get out of our country, right? We don't want your disease here, right? Well, realize that in 1.4 billion people in China, right, 80,000 got the disease, and they contained it. And as you heard, the numbers going down, and they very much contained it. In Korea, it's a little bit more of a problem now, but they're actually fighting it, and they're fighting it in a way I don't even know that we would be able to put together an effort like they did in Korea now, right? You drive up and get tested in your mouth, right? Very, very responsible to make sure that we're not the vectors of disease or spreading it to others in their own countries and actually traveling here. And so, I think it is a very important thing to keep in mind that this is not an Asian disease per se, right? Anybody can get it. Everybody in this room is at risk. It's not just Asians, and we're not the only ones, I haven't been exposed to anybody. I haven't left the country, but people look at me and they could, be concerned because they're being cared for by an Asian doctor and they don't know. I know in my own practice, I'm a radiation oncologist, but I have patients who travel from all over the world. And they ask me the questions. Should I go? Should I cancel my trip, right? I do think that right now it's a little concerning because we don't have all the answers. As Dr. Alice explained to us, that we maybe shouldn't be, thinking about taking my trip to China right now, right? No, I haven't been to China in a long time, so don't worry. But, it is something that, you have to be prudent and you have to take care. It's not the most deadly virus out there. We get that part. But who wants it? Nobody, right? And we certainly don't want to come back and be a vector. But the Asian community should not be looked at as any more risk than others unless they are coming from China, right? Or Korea, or an area that's at risk. I know at Temple, and I'm from Temple, that we ask those questions to every patient that comes in, right? Have you had recent travel? It's built into our medical record. We have a 40-man and woman team ready to handle any case that would come in, okay? So your hospitals in the city of Philadelphia, we are prepared, we are screening for it, we are looking for the symptoms. Have they traveled? Have they been in contact with people who traveled recently to these nations that are at high risk, to Iran, to Italy, to Japan, to Korea, to China, obviously. And so we're looking at all of those things and we're being prepared. But what I would certainly admonish you not to do is to look at Asians and say, oh, vector of disease. Because, we're not. No more at risk than anybody else, okay? It did happen to start in China, but it could easily have started in Philadelphia, right? It could be a virus that, for whatever reason, mutated, the coronavirus, and started something here. And how would we want to be looked at, right? Oh, they're from Philadelphia. No, they're vector of disease. Stay away from them. No. So I think it is important that we look at this, and we look at this as a global issue. This is a disease that is not racially targeting Asians and then going out to other people. It is to anybody and everybody. So if you have symptoms, if you are in contact with people from those areas, you might want to, if you're concerned, you might want to just, make sure that you are distanced and, hand sanitizing and all that. Do you think a couple of bottles up here? Because we live by that too. And of course, the other side that I'm going to touch on just for a second is as a healthcare provider. So now I'm seeing patients and I'm at risk, and to be honest with you, I'm sitting there and I don't know, and I'm not going to have an N95 mask on my face at every patient that I see that comes into the room and say I'm going to protect myself, and I don't know, because any one of you could give it to me, and I see lots of you every day, right? And so, it is something that, we have to be sensible as well. We know that we're at risk. We take it very seriously. And if we have contact, we are the first ones to go and get tested to make sure it doesn't happen, right? So somebody just came back from Italy, right, to Massachusetts and tested positive, right? And those kinds of things. They were involved in healthcare. And so I think, we have to be cognizant that any of us, it could affect any of us, that it's not an Asian thing, that this is really, truly a global effort and a global disease. Many countries. It was interesting because I had a Canadian patient who said, I'm going to go to Italy. Should I cancel my trip, right? And there were over 40 cases in Canada itself, right? And going from, and I said, basically, obviously, the one thing we don't want to ever do is go on a trip like that, which is a trip of a lifetime, right? Scared. So I've told people, listen, if you're concerned, I'm concerned, cancel your trip. Don't put yourself at risk. Don't go to Disney World right now, because my daughter just canceled her trip to Disney World, because that's an area where you have lots of people from all over the world to go there. And it's just, how could you have a good time when you're worried about that, right? So, we have to be cognizant. We have to be comfortable. We have to always, be cautious. And it's not just this, right? It's not just COVID-19. It's influenza and everything else that we are exposed to. And certainly, I live in the cancer world, so obviously, all the things that could affect you in cancer, right? Smoking, things like that. So that's all I have to say. Yeah, thank you.
Thank you, Dr. Miyamoto. That's very enlightening. Yeah. So, I suppose, yes. Do you have a question?
What is the cause of COVID-19?
Okay. Let me first set up a guideline for questions. Miss Rebecca here, Miss Rebecca Ray, is going to.
We're going to have people line up here if you have a question.
So she's going to have.
We only have one mic.
We only have one mic, and we want to tape this on our podcast and present it on the library website. So come on up.
So if you could come up and speak below the radar.
Would you like me to repeat your question?
Yeah, as far as research goes, what are the factors, or what are the causes of COVID-19? What do they suspect to be the causes of that
Okay.
disease?
So the question is, as far as the research goes, what are the causes of COVID-19? Does that encapsulate your question? Okay.
As was said, there's no medication,
There's no medication, there's no vaccines.
But what does the research show?
What does the research show? Who would you like to have answer your question?
Any.
All or any? Okay. Who would like to go first?
I'm happy to go first.
Okay, would you like to come to
Should I
the
stand
podium?
up here?
Because
Is that
that's
what
the
you'd
only
like?
way we can record the podcast. So thanks, Dr. Alice. So Dr. Alice will start with a response.
So to answer your question, what is the cause of COVID-19 disease? The virus, it's called SARS-CoV-2. That's the name of a virus that causes the disease. But is your question more,
You mentioned bats, some other animals.
okay, so that gets to the origin of where this particular virus comes from. And so it's a now known animal coronavirus that has evolved and been able to jump to other animal species and ultimately has come in close contact with humans to cause disease in humans, and then now spreads more rapidly in humans. So viruses have the ability, because they replicate in other living cells, to replicate very quickly, and some have the ability to mutate when they reproduce, meaning that they change their genetic construction so that they can now be different and infect new, different kinds of cells in respiratory. Try not to use too medical jargon, but the point is that this is a virus that has changed from animal species and now can infect human beings better than it ever could before.
I have one question, but I'd like you to answer it real quick. How do you differentiate with flu that's going on now and this? What test do you take, or what blood work do you look at to say, okay, this is the flu?
I can repeat her
or this is
question
the
if you'd like me to.
coronavirus?
So your question is, what tests exist that detect the difference, or different diseases like influenza or coronavirus?
No, whatever flu that's out right now and the coronavirus, how do you weigh the difference to say, no, they have the coronavirus, or no, they have the flus that's out today?
Right. So the question is, how do you know the difference between somebody that might present, because clinically they are similar with respect to fever, cough. How do you tell? And right now, here in the United States, the way to consider somebody who might have coronavirus is because they have what we call an epidemiological risk factor, some other element that put them at risk. And right now, that's predominantly travel to a place where there's a lot of cases, or close contact with a confirmed case, like a healthcare worker who took care of a COVID-19 patient. So if somebody right now, if any of us in this room were to present with fever and cough, it would be more likely presumed to be influenza or another routine virus that's circulating in Philadelphia right now. But we should all be asked the questions by our healthcare providers: did you recently travel? And if we didn't recently travel anywhere, then we should get tested for routine viruses like influenza. Does that make sense? So it's the exposure risk is part of the determination. Where were you?
If I flown to China or something, and I presented with this, then instead of you looking at me having the flu, you looking at me probably having coronavirus.
You could have either. I mean, yes. Yes.
Thank you.
You're welcome. Do you want me to field questions, or do you want to moderate?
Yeah, I can moderate, sure. Okay, who was the next person? Boy, so many hands. Go ahead.
A quick remark that if you are going to send emails out to alert people, you're going to miss older people who do not have computers.
So the comment is, if,
And that radio or other methods would be important. You can't rely on email.
the comment is you cannot rely on email for the senior population, you need to go on the radio, or use means that will specifically target senior populations in Philadelphia. Does that encapsulate your thing? Okay. Next person, yes.
As of Friday, the CDC said that they didn't have a way of testing nationally. Had that changed?
So this, the comment is, or the question is rather, the CDC doesn't have a way of testing, and has that changed? Or will it change?
It wasn't, the testing that they was doing was limited, and it wasn't national.
Okay. I think I understand your question. And so originally, all testing had to be approved by CDC through local health departments like ours. And the specimens for testing had to go to their lab down in Atlanta, Georgia. That was true for a handful of weeks. Today, we can celebrate because actually our state public health laboratory, every state has one, and ours is located in Chester County, is operational now to do the testing. And so the expansion of laboratories in our whole country to do the testing for COVID disease 19 happens now. And so we're able to test more people, the shorter time frames to get the results back, that's all present now this week.
Okay.
Okay? You're welcome.
Oh,
I'm happy
Okay.
to just field
I know
questions.
that there's an 80% asymptomatic rate, people who don't show symptoms, but I'm over 60 and I'm a diabetic, so I wanted an idea of why diabetes is one of the chronic underlying conditions.
Yeah, so your question is around why is diabetes an underlying health condition for COVID disease 19 and probably other infectious diseases as well. And diabetes does a number of things to the body over time. And so it impairs renal function, and it also affects the immune system. And so a combination of different metabolic dysfunction, I'll say, in different organ systems throughout the body just make an individual who's had diabetes for a long time, maybe less controlled than others, to have worse outcomes from when they get exposed to an infectious disease.
So is uncontrolled diabetes or just diabetes generally?
I don't know the data to say that levels of people with different diabetes over an extended period of time, A1C is a measure that people might know about if they're a diabetic, to know that that's something to measure over time. I don't know the correlations between increased rates of different diseases related to less controlled diabetic patients. Dr. Miyamoto, do you have anything to add on that subject?
Well, I certainly would say this, that if you have uncontrolled diabetes, you're at a greater risk from uncontrolled diabetes than you are from an infectious disease. And it does affect your immunity, and so yes, it puts you at a high risk, but I mean, honestly, if you have uncontrolled diabetes, that's your number one priority. Control that.
If it's controlled, then you shouldn't be as scared as you would seem to be from the news reports.
Correct, and you shouldn't be as scared with your diabetes, because your diabetes, being controlled is certainly a much better thing, period, for your health.
Talking about
As far as your ability to be infected by the coronavirus, controlled diabetes certainly would help. I don't know, there's hard data to say one or the other, except that if your diabetes is not controlled, that's a very bad thing, right? It could take you tomorrow. So,
my question is regarding control, the word control. Is that to include control by means of medicine or by means of exercise and diet? Which control? If
So-
your diabetes is controlled,
correct.
then the chances of your contracting a respiratory disease such as the cold, the flu, that virus is lessened if your diabetes is
Well,
controlled. So what does
it-
control mean?
So it doesn't, I mean, whether you get the disease or not, it depends upon your exposure, right? And so, you're not protected because your diabetes is better controlled. It doesn't protect you. What protects you more than anything else is exposure to the virus. So if you avoid that, then you are protected.
Take one more question, gentleman right in the back.
I've heard that, of course, it originated from China, that they come from animals to hold it. We can only presume that coronavirus came from a person from China's initial interaction with one of these animals, correct? So how they contracted, right? Their initial communication or exchange with an animal who had coronavirus, correct? That's how it spread to a person in China. That's how it originated, correct?
So your question is addressing how...
Yeah, the origins. I know you said that animals carry coronavirus. I'm going to imagine that because we are people that we contracted from our interaction with one of these animals. We don't know which animal necessarily it was. We don't know which animal the person contracted it from, but animals contain it first, correct? So there's some type of initial contraction from an animal.
That's right, yes. So the virus was contracted from an animal.
Well, of course, we don't know which one it was, but it was an animal that contained coronavirus.
Bats typically are the primary reservoir for coronaviruses.
And one more, I want to say that viruses can they be, when a person is testing for a virus in general, what is the influenza, which is a virus, right?
Correct.
And can, when a doctor is testing for it, can there be a distinction? Like, can it be to the point where they can recognize which virus it is? Because that's what I think she was asking. Like, if, you have symptoms of, a respiratory and a cold, but X, Y, and Z, how could you tell whether or not it's influenza or coronavirus? Like, when you do the test, does it come up like, a type of diagram to show that which type of virus it is in particular? To quote unquote show which one?
It does. So the question is, when you're tested for a respiratory virus, among all the different respiratory viruses a clinician might be thinking that a patient might have, are there different tests? What does it look like, the results? And so, yes, there are multiple tests for specific viruses and bacteria that cause flu-like illness, so fever and respiratory problems. And so the clinician has to order those different tests for influenza, for other viruses like RSV, rhinoviruses, adenovirus, parainfluenza. There's a whole host of other viruses that cause flu-like illness.
So what's the test look like for, did they administer a test specifically for coronavirus?
Yes, there is a specific test for this novel coronavirus.